Well, yeah.
Or do they need?
If you have a PPO, you can go. If your insurance is a PPO, you can go directly to the podiatrist.
Okay.
If it's an HMO, you got to get an authorization from the primary care physician. They call it the gatekeeper. They tend to decide, that if there's a problem, then they'll give you an authorization for 3-4 treatments to do whatever you need to do.
Oh, I see.
Right. And most plans will include that because what they'll find out is that it's cheaper if I see it and take care of it without it clinically getting worse, where it may need to be hospitalized, the chronic get worse and may need surgery, maybe there's something that's preventable. And so that's why in an integrated healthcare system, you need to educate all the individuals in, of course, primary care, family medicine, internal medicine, where they rotate on my service, learning about the foot and ankle when they're a resident, so that you get to teach them about the common problems and how they should be managing them. Yeah, so that's the best. It's like in a professional piece when everybody's at the table from day one, so that they pretty much learn scope of practice, what you do, and how to utilize one another, and how to work together in a team. Yeah, that's kind of what the last discussion was in the previous session with the deans. We talked in the other session about academics in terms of teaching. We definitely need that. The government, you have the Veterans Hospital, Indian Health Service, Center for Disease Control, NIH, where a lot of research is done. And Health and Human Services covers all health care for everything. And so, but you can get jobs in every aspect. You have to go to prisons, you have podiatrists that work in the prison systems, just endless. Everybody walks in, everybody feet hurt, and so there's a huge need for care. So you never have to worry about having a job. You never have to worry about being busy if you're a good podiatrist and well trained, and practice comprehensively. And that means you got to trim somebody's corn and callus and keep them comfortable. But at the same time, you got to know why they have the callus and treat them why versus just trimming it. And that's the difference in Dr. Scholl's session. If you go to the pharmacy and look, there's a session for foot and ankle stuff, and they sell you all these different things. It's not about does that make me feel better, but why did I develop the problem? And that's where you have to go to the doctor so that you know that and know why. A lot of times patients will go buy stuff on their own over the counter, put a Band-Aid, I call it putting Band-Aid therapy on it, because it's just first stage. It's not treating the cause and why, if that makes sense. Hospitals, podiatrists can be hospitalists in the hospital. Health plans, you can be the chief medical officer for a health plan. Or you can do a carve-out. You may go to Blue Cross Blue Shield and say, I want to see all your patients for diabetic foot problems. And because I'm so well trained that I can do it better, faster, quicker, and for you to be able to go out and promote that drug or whatever it may be. And so podiatrists, we participate in clinical trials. And so the profit margins is probably higher in that than it is in seeing patients. But you got to have a practice to have the patients that can participate in the clinical trial, if that makes sense. So those things are all tied together. So a lot of guys that are even doing better now, not only do they have clinical practice, but they also are involved in research and clinical trial business. So it's a huge opportunity. This area here when I was at the university was how I generated my biggest profit margin, which allowed me some flexibility to invest in things that I wouldn't have been able to do. Which means that I could enrich faculty by letting them go do 2 weeks here, a month there, for faculty development, or whatever I wanted to invest in. So if there was initiatives that we want to do to provide better care, to generate whatever we need to do, the research part was enough that I would generate money that we could be able to do that. First 2 years in medical school is podiatric medical school is the same as medical school. We take all the same classes, and you have anatomy, biochemistry, physiology, pharmacology. We do all the systems. You may have blood and lymph. You'll have musculoskeletal. You'll have dermatology. You'll have the neurological system, et cetera, et cetera, et cetera. And so you have to learn all of that to understand the science of everything in terms of how these things, how it works, what is it, and the relationships between what it is and all these other things that allow the body to perform the way it should perform. And that's the best part of medicine is the science of it. Because if you understand the science, then you can explain it to the patient. Yeah. And everybody will treat stuff, but so you have a problem with your cartilage in your knee. Well, what's the basic biology of cartilage? And how does it heal? How does it get disease? And if you have a certain disease, how does that, is it going to get worse? Is it going to get better? The same? Can I treat it conservatively, or do I have to do surgery? You understand what I'm saying? So that's why you have to stay and read and keep up, because things change at the basic science level on an ongoing basis. In the third and fourth year, curriculum. We do 3 months of medicine rotation, 3 months of surgery rotation, just like a regular MD, ideal medical student. And we rotate on all these other services here. But we also start spending more time studying the foot and ankle. So in the third year and the fourth year, we basically still do about 4 months, 4 or 5 months of general rotation, but about 7 months of that is out just strictly podiatry, where you go rotating hospitals around the country where you prefer to go train. And because you have to do 3 years of residency, so you want to go in to places that you think you want to train so that you can make that decision, if that makes sense. Is our residency requirement? Yes. 3 years of residency is required. So you finish the 4 years, you get your DPM degree, Doctor of Podiatric Medicine, and then you do 3 years of postgraduate training in medicine and surgery of the foot and ankle. So we rotate in the first year, a lot of general rotations, like emergency room, radiology, internal medicine, maybe family medicine, do some dermatology, epidemiology, and podiatry. And then as you continue to move up, you spend more time in the surgical management of musculoskeletal system from the foot and ankle perspective. After you finish the 3 years, some people want to be more specialized, so you can do fellowship training. And these are some of the areas where you can do a fellowship. I had a fellowship with diabetic foot in terms of amputation prevention. So I had a couple of fellows that would spend at least 1 year, a couple of them spent, one of them spent 2 years in a fellowship. That means they were getting more specialized training in a specific area. And so you can do that in sports, pediatrics, geriatrics and aging, surgery. So some people do a fellowship in trauma, where you ride a motorcycle, you fell and broke your ankle, you fell and debugged your heel. I used to get a lot of people that the train ran over their foot because they were the immigrants from Mexico and all that. So I've seen all the kinds of injuries that patients have. There's a thing called AO International where we learn how to put different plates and screws.